Yeah, so I'm Robert Thomson. I'm an intensive care and anaesthesia consultant in Fife in Scotland, and it's a privilege to speak to you a little bit about my practice with using HPI and hemisphere monitoring. My clinical practice in anaesthesia involves upper limb operations for dialysis access and major operations for colorectal surgery, as well as being an intensive care consultant in a mixed critical care unit, general patient, surgical and medical. So colorectal patients that are coming for surgery are really presenting as quite a variety of different clinical conditions. You can have patients that are very young and healthy and straightforward who are having an operation on their colon for inflammatory bowel disease, or you can have quite a frail elderly patient who's coming for an operation on their colon for typically cancer. And the chronic health problems would be fairly typical for the Western world, where you would have patients who perhaps have hypertension or diabetes, maybe ischemic heart disease with events previously, sometimes having had a cerebrovascular event, a stroke before, as well as more commonly now, because of the advanced age and sometimes frailty of patients, you can have patients who have chronic kidney disease in the background and end organ disease from hypertension, ischemia from their heart, and kidney disease as well, and diabetes. So it's really quite a mixed bag of patients that we're seeing coming for colorectal surgery. So it'll be common practice to deliver anaesthesia for a patient undergoing colorectal anaesthesia and surgery for them to have an arterial cannula in place to have intra-arterial blood pressure monitoring. So we've got really quite invasive and accurate blood pressure measurement going on continuously for these operations, and that would allow you to manage MAP, mean arterial pressure, mainly to avoid hypotension intraoperatively. A lot of the focus is on pre-assessment for these patients to try and optimise them before they end up coming for their operation and for their anaesthesia. For the more high-risk patients, then historically and traditionally I've used maybe an esophageal Doppler probe for fluid management or pulse pressure variation, using the intra-arterial blood pressure to then guide fluid management and the like for cardiovascular optimisation as well intraoperatively. So I think that over the last few years there's been an increase in the amount of evidence suggesting that any periods of hypotension during an operation is bad for the patient, and outcomes can be affected substantially, not just by individual events of hypotension, but actually the cumulative periods of hypotension over the course of the whole procedure. And so I think myself, along with many colleagues across the world, clearly have been reading and reviewing this type of research with interest to see how does this affect the patients that I care for and look after. And so I think I, along with many people, have had our attention brought to the fact that managing and preventing intraoperative hypotension is good practice and probably reduces the amount of complication that the patient can sustain post-operatively. I think that I've been intrigued by the hypotension predictive index that Edwards has introduced with their Acumen sensor, and I think that it's a very useful tool, especially in the higher risk patients, to actually allow us to intervene and to prevent hypotension from occurring at all, or certainly to reduce the total duration of hypotension during an operation. I think it's certainly become clearer to me with research and evidence and more and more retrospective analysis of data that hypotension is a big factor in how patients do after their operation. I think this has become more of a focus for us to try and manage during an operation. And I suppose a few years back, with enhanced recovery for colorectal surgery, we were, as anaesthetists, really trying to improve outcomes with good pain management, good optimisation before an operation, but I think our attention has been shifted from these things where we've done good work in improving intraoperative practice and improving the perioperative period and management of patients in that phase, to now saying, well, what can we do about hypotension? Can we prevent significant complications, things like myocardial infarction, acute kidney injury, perhaps even delirium, by just preventing hypotension from occurring during the operation and post-operatively as well. So I've been intrigued really by the new technology that Edwards have introduced, and I think that there's been a whole lot of work and research and innovation put into devising this, I suppose, innovative way of monitoring patients during their operation and in the critical care area as well. I think that the parameters that you get using the Acumen sensor, things like EA-dyne and delta P over delta T and stroke volume variation, these are useful indicators and parameters which are very helpful for managing patients during their operation, but I think that the hypotension prediction index is really quite a remarkable parameter that we now have access to with this technology, and it, to my mind, from clinical practice and from seeing it being used in real life settings, is very helpful for allowing me to decide in how to manage patients in a way that prevents hypotension from developing, and if that's not possible, at the very least to reduce the total duration of hypotension that the patient has experienced during their procedure. So I think historically we've been using vasopressors an awful lot in anaesthetic practice. I think that when it is that a patient is developing hypotension, the default position more often than not is to, I think, correctly assume in most occasions that there's vasodilation occurring, and that is due to a multitude of reasons, due to the opiates and anaesthetic drugs that we use. Most drugs that you give by intravenous route cause vasodilation, so we've defaulted to the position of giving vasoconstricting drugs to treat hypotension during anaesthesia, but clearly that's not always the case, and I think that it is useful to adopt cardiac output monitoring to try and guide us, to tell us, direct us towards, well, is this hypotension that's impending, as hypotension predictive index can allow us to identify, or is this hypotension that's happening currently because of hypovolemia or perhaps an impaired left ventricular function, or actually is it just that it's vasodilation? And so I think the HPI can help us to predict impending hypotension, but I think cardiac output monitoring more generally can help us to decide based on clinical experience. I don't think it replaces the expertise and skill and knowledge of a well-established anaesthetist, but I think that it is helpful to guide us and lead us to good decision making for patients and to give the treatment which is most appropriate in that circumstance. Yes, so I think that the secondary parameters that you get with Acumen, with the Acumen sensor is useful. I think that the starting point is to identify whether hypotension is there with MAP measurement or impending with hypotension prediction index, and then I suppose directed from there, if there's an abnormality, to then move down in your secondary screen and decide, well, is there a stroke variation, stroke volume variation situation here where we could identify, is giving more fluid going to be helpful in collaboration with your EA-dyne ratio and also your delta P, delta T, to just give you an idea using your protocol that you've probably introduced in your own hospital, which we've done, and I think that's good practice, to then direct you towards what's the likely cause of hypotension here and how can we fix it. So I would say that the feedback that I'm getting from colleagues who have used HPI has been all positive, really. I think that there's been an increase in enthusiasm as people have used the hemisphere monitor with Acumen sensor in place clinically in patients during major operations, that the attitude is really one of positivity, that it is a helpful monitor to use in patients that are at high risk of developing complication post-operatively. And I think that with practice and with self-education and reading up on the topics and reading up a bit about the parameters that the hemisphere is able to tell us about, that colleagues, including myself, as I've gained experience of it, that we've really felt that this is a novel, innovative technological advancement which is really helpful for us to make good decisions for patient care during the procedures. I think that seeing it in action clinically really is quite a convincing thing. I can see why it is that anaesthetists would initially be a bit uncertain and unsure as to what is this additional layer of monitoring going to give to me in clinical practice. How's it going to aid? How's it going to assist me when it is that I'm making decisions during anaesthesia and during an operation? But I think with actually trying it out, I suppose, and seeing it in practice, people recognise fairly quickly, I think, from what I'm seeing with colleagues, that it's a very dependable additional parameter, particularly HPI, for identifying patients that are at risk of hypotension and then dealing with it in a timely manner. So it has been predominantly colorectal patients that we've been using HPI measurement on in my local hospital in Fife. I think that what we've found though is that any major abdominal operation locally in our hospital setting, I'm thinking of things like major urological procedures, gynecological operations, as well as upper GI and lower GI surgery. I think that these are patients, if the operation is of sizable magnitude, that this is additional monitoring which adds helpful and directive, I suppose, guidance for us to make good decisions during an operation. But my experience is not in the field of transplant surgery or cardiothoracic surgery, but I can see in these patients where the complication and adverse event risk is even higher, that it would be even clearer that there's benefit to be had from this extra layer of cardiac monitoring to actually enable us to manage fluid and vasodilation and all these things which impact on hypotension at the different points in a patient's journey through and after their operation. So I think when it is that you're introducing a new treatment or a new innovative aspect to patient monitoring in any area of the hospital, I think that the challenges are pretty consistent. It's about initially getting clinicians intrigued and interested in the actual innovation. I think that it's about allowing colleagues the opportunity to actually see it in practice, and maybe that is in a lab training setting or in simulation, or if the opportunity allows to actually have it in clinical practice in a real life setting. And it's really about trying to, I suppose, allow clinicians the opportunity to see new things and then to wonder about whether they could introduce it themselves. And then I think it's about educating people, because you're not going to get people keen on changing their practice unless they have a good understanding of what the treatment or new monitoring equipment is able to offer them and whether they feel confident in it. And so I think that Edwards are very good in allowing and making available opportunities for education, whether that's online or in person, and I've certainly found that to be helpful in my own increasing confidence in Acumen sensors and HPI technology generally. I think there's clearly a cost element, no matter where it is in the world that you work. I think that Healthcare is a business, and we're trying to do things in a way which keeps costs down, either for the patient or for the government, which is involved in funding healthcare. Certainly in the UK, that's the setup we have. And so there's an appropriate attitude where we don't want to be spending money on things which are of no value, but I think that the evidence is there to be seen that avoiding hypotension for patients undergoing major surgery is a good thing. And I think that the cost-benefit analysis, when you look into it, does seem to stack up for the introduction of hypotension prediction monitoring intraoperatively. We are certainly confident and hopeful that we'll see a reduction in length of stay in critical care areas, because this extra additional layer of monitoring has the potential to reduce the complication rate after an operation, and that's a good thing for the patient, but it's a good thing for us as a healthcare organisation. Whenever you're introducing a new treatment into a healthcare setting or a new technology, in this case cardiac output monitoring with HPI technology, I think that the difficulties and obstacles that you face are quite predictable. I suppose it's the same in any setting of business. You really need to get people on board, and that really takes the form of a starting point where it's to do with educating clinicians as to the potential benefits of this new technology. And I think with HPI, it's really about directing people to the potential avoidance of complications such as myocardial events or acute kidney injury post-operatively. I think it's also about bringing in experts, and for the initial phase-in period, have on hand, or at least available, someone who's able to answer the questions that come up when it is that somebody's getting used to this new mode of monitoring. And I think that Edwards are very good at giving assistance with that. There's good online education opportunities. There's the provision of somebody coming on site and helping you with the rollout of using hemisphere monitors with the HPI measurement. And I think also it's about probably getting a core group of people together who are enthusiastic about it and who are keen to see it being successful, and building up a head of steam to actually see it being used frequently. I think having a protocol in place is good as well. I think that's true of any new mode of treatment that you introduce in the hospital setting. I've found that with other things. So I think that with HPI, having a protocol which is fairly prescribed and directive for people to actually follow, triggered with the hypotension prediction index score initially with the map, and then leading you down a protocol where you assess stroke volume variation and assess EA dying, and then with suggestions as to how you treat patients depending on what limb of the protocol they're on. I think these things give people the necessary backup and confidence to be able to get established in using things like HPI, and also to feel a sense of reassurance that they're doing the right thing and that they're on track with their own clinical practice as they use this new type of technology. We found that in practice locally, and it's been so far a fairly successful rollout amongst a few of our clinicians. Yeah. I'm pleased to say that our own managers locally in the health board that I work in here in Scotland are very open to innovation, to introducing new technology. We've seen that with various surgical specialties, including anaesthesia, and so they've been very receptive to our request to start using hemisphere monitors with Acumen sensors. I think unexpectedly they were obviously intrigued by the cost and the change in practice that this was going to bring about, but I think with ourselves looking at the potential improvements for patients, the avoidance of post-operative complications that are there to be had potentially by avoiding hypotension, and particularly cumulative duration of hypotension during an operation. I think that, you know, we're working in healthcare settings where anything that improves patient care is something that clinicians and managers are receptive to. And I think that even on the level of analysing cost, if it is that we're able to reduce the length of stay in critical care areas, particularly high dependency units, post major operations, then that comes with its own cost savings and also bed pressures, and allows us to not be in a position where we have to cancel operations from happening due to a lack of critical care beds. So all these things really built up a good level of persuasive argument when it is that we came to request that we could start using HPI and Acumen sensors in our patient groups undergoing major operations. So I think that the hemisphere monitor with the Acumen sensor makes available to the anaesthetist information that's very useful. I think that the hypotension predictive index is, to my mind, a very reliable and dependable parameter which tells the anaesthetist in advance of what is impending hypotension and allows the clinician the opportunity to intervene at an early stage and avoid hypotension from developing, or at least reducing the total duration of hypotension for the patient. So that's a very helpful parameter and useful information. I think the secondary parameters are good as well. I think that many of them are directly measured, and so stroke volume variation, delta P, delta T and EA-dyne, I think these are helpful additions and extra parameters and good information for the clinician to have at hand to then enable them to make decisions which are treatment specific about how to manage the hypotension and how to prevent it as well, hopefully. So the Acumen cuff, which is about to be introduced, strikes me as being a very interesting and novel opportunity for intraoperative blood pressure measurement. I think that clearly the opportunity to monitor some of these cardiovascular parameters without the requirement of an intra-arterial cannula strikes me as being of real interest to the anaesthetist. I think that there's certain patients having high-risk operations where you're not really wanting to insert an intra-arterial cannula if it can be avoided. And so I think that it allows the opportunity for an anaesthetist looking after a patient undergoing orthopaedic procedure or perhaps an obstetric patient. It allows the clinician the opportunity to continuously measure blood pressure with the associated parameters that the hemisphere monitor allows us access to, and has the potential to give good direction again for the clinician to make decisions about avoiding hypotension and treating it when it does occur. So I'm intrigued and I'm looking forward to using it, and I think that if it stands up to the scrutiny which HPI has with the introduction of intra-arterial means of measuring these things, I think that it could really be a game changer in some areas of major risk surgery.